Well, let me extend a warm welcome to you today for this event, which is a celebration of the International Day of Older Persons. And we're focusing on scaling up physical activity for older persons. Now, as is our custom in Australia and in many countries around the world, we like to recognise the traditional custodians of the lands in which we're meeting. I'm on the lands of the Gadigal people in Sydney, Australia, and we acknowledge the tradition of custodianship and law of the country on which we present to you from today. And we further acknowledge the traditional owners of the country which you are on and pay respects to their elders, past, present and future. I'm Ben Smith. I'm one of the co-directors of the WHO Collaborating Centre for Physical Activity, Nutrition and Obesity, and we are one of the partners organising today's event, along with the Sport and Physical Activity Research and Teaching Network at the University of Sydney, WHO Physical Activity Unit and the International Society for Physical Activity and Health. So that gives you some sense of the breadth of support that there is for promoting older people's engagement in physical activity. We're going to have a full program today. We have a tremendous range of speakers from around the world who are going to talk to us about the importance of physical activity for older people and give some examples of significant initiatives that have been conducted around the world. We very much like to encourage your contributions, and you can start doing that by using the chat function, letting us know where you're coming from. We'd love to hear all the different corners of the world that are represented in today's event. And also, as we go through, we also want to let you know that you can use the Q&A function to post questions, and our presenters will take opportunity later on in today's session to answer those questions. So please remember to use the Q&A function for questions and the chat function to let us know where you're coming from. Also, you can join the conversation on Twitter. We have a hashtag, as you can see there, hashtag UniDop2022. Well, as I said, this event is being co-hosted by a number of leading organisations. Among those are the WHO Physical Activity Unit. So I'm going to hand over to Dr. Fiona Bull, who manages that unit, to give a welcome to today's event. Following directly on from Fiona, we'll have a welcome from Associate Professor Karen Milton, who's the President-elect of the International Society of Physical Activity and Health. And she's also an academic staff member at the School of Public Health at the University of East Anglia. And then directly after that, we're going to have a video presentation, which is going to overview the evidence about physical activity for older persons and highlight some of the resources that have been developed by the WHO, and that'll be presented by a number of people who you'll see in the video. So I'll hand over to Fiona.
Thank you very much, Ben. And can I add a very warm welcome from WHO to this seminar to all of you around the world. And I'm seeing from the chat box, we really do have coverage coming in from many parts of the world. So thank you all for joining us. Can I also thank the organisers, Ben, your team, and of course the Collaborating Centre led by Kathy's work on older adults. Thank you to ISPA and thank you to the other partners. We're marking the International Day of Older Adults, a really important day and weekend as it will follow over the next few days. We're at the start of this celebration, and it's really important that physical activity is part of the conversation. Because in 2018, the Global Action Plan on Physical Activity highlighted the importance of physical activity for everyone. We launched Let's Be Active, everyone, everywhere, every day. And it's inclusive and included older adults. And yet today, we'll hear about the data showing that we need to do more. Just in 2020, we emphasised the importance with the new guidelines, every move counts. And again, today, from our speakers, also from around different quarters of the world, we're going to hear about the benefits and the importance for preventing disease and promoting health and well-being, mental and physical. Delighted to join this. Thanks to everyone. Really looking forward to this rich programme. I think I hand to Karen. Thank you very much.
Hello, I'm Karen Milton, President-elect of ISPA. On behalf of ISPA, I'm delighted to welcome you to this webinar, which we're co-hosting with the WHO Collaborating Centre on Physical Activity, Nutrition and Obesity. It's obviously great that we're making progress on the prevention and management of NCDs, but of course a consequence of that is an ageing population. We need to support older adults to be more physically active, and in this webinar we'll be hearing more about how we can do that. So welcome from ISPA, and I hope you enjoy the webinar.
And as I said, we'll be transitioning directly now to a video, which has been prepared by the team from the University of Sydney and Dr. Joanna Williamson.
Hello, I'm Associate Professor Anne Tiedemann from the University of Sydney. And today I'm going to be talking about the World Health Organization Global Guidelines on Physical Activity and Sedentary Behaviour. The guidelines are based on a summary of extensive research evidence and were put together by 30 global leaders around the world. They were released in 2020 and they provide evidence-based recommendations on the amount of physical activity that's important for enhancing health and preventing chronic disease. In terms of the specific recommendations from the guidelines for older adults, first of all, the overall recommendation is that all older adults should take part in regular physical activity. The first specific recommendation is that adults should undertake at least 150 to 300 minutes of moderate intensity aerobic physical activity, or 75 to 150 minutes of vigorous intensity physical activity each week, or a combination of both. Secondly, in addition, on at least 2 days of the week, older adults should take part in muscle strengthening activities at a moderate or greater intensity. And these should include all major muscle groups. And this is to ensure we maintain our ability to keep independent and keep doing the things that we enjoy. Additionally, on at least 3 days of the week, older adults should be taking part in varied multi-component physical activity that emphasises functional balance and strength training at a moderate or greater intensity. And this is really important to maintain functional ability and prevent falls. Overall, the key points from these guidelines are that doing some physical activity is better than doing none. If you're not meeting the recommendations, or if you're not able to at this point in time, doing some physical activity will bring benefits for your health and well-being. It's important to start by doing small amounts and gradually increase the amount and intensity of activity. Be as physically active as your functional ability and fitness allow at this point in time.
My name's Heidi Gilchrist and I'm going to present the results of a rapid review my research team and I conducted in order to inform WHO and others regarding the effectiveness of physical activity programs and services for older adults on various outcomes by examining individual studies. I'd just like to acknowledge the great team we had working on this, led by Dr. Marina Pinheiro. Firstly, 8,267 primary studies were identified and full-text screened, and we found 1,421 intervention studies met our PICO criteria. Our criteria for inclusion of primary studies were intervention studies which involved adults aged 60 plus that compared the impact of a physical activity program or service to no intervention or another intervention on different outcomes. Next, to consider the impact of different types of physical activity programs, for example, physical activity promotion, structured exercise or sport, compared to no intervention on different outcomes, we took the interventions which were RCTs with at least 50 participants per group and a Pedro quality score of 6 or more, and extracted detailed data using a framework that we developed for the purpose. The intervention effect for each relevant outcome was categorised, and a positive effect was defined as more than 50% of between group comparisons being in a positive direction. What we found was that the results of these moderate and high quality larger trials were overwhelmingly positive in favour of physical activity. There were different impacts in different areas, however. For example, we did find different types of physical activity had different impacts on the outcome domains investigated. This figure shows the effect direction and statistical significance for outcome domains across primary studies. The number in each cell represents the number of intervention groups, and the larger the circle, the larger the number of intervention groups. The shading depicts overall positive effect direction, so the darker the colour, the higher the proportion of positive effects across comparisons. An asterisk indicates 50 to 75% total outcomes were positive and statistically significant, and 2 asterisks means the greater than 75% total outcomes were reported as positive and statistically significant. So on this slide, there are 3 main findings we can see. So if we look at the second column, to increase physical activity levels, the strongest evidence was for programs that promoted overall physical activity. So an example of that would be coaching. Looking at the third column, to reduce falls, the strongest evidence was for structured exercise. And looking at the second last column, to improve cognitive and emotional functioning, the strongest evidence was for recreation. Other key findings were that physical activity programs are beneficial for older adults with physical, cognitive and emotional impairments, and programs are also beneficial delivered in various locations. So we make several recommendations in our report. For example, further primary studies are required in a number of areas, such as sport interventions, low and lower middle income countries, and physical activity in underserved or disadvantaged populations. Also, we didn't consider cost effectiveness of these programs, but Marina has led some research around this, which leads nicely into her talk. So I'll leave it here, but there will be references at the end if you want to read more about this research. Thank you.
Hello, my name is Marina Pinheiro, and I'm going to present a study we conducted investigating the value for money of fall prevention exercise programs. Exercise reduced the rate of falls by about a quarter in older people, but do they offer good value for money? To answer this question, we conducted a systematic review. We identified 21 economic evaluations investigating the cost effectiveness of fall prevention exercise programs for older people living in the community. The main outcome of this review was the incremental cost effectiveness ratio, expressed as costs per quality adjusted life year gain, or QALY. So if we were to implement an exercise program, this would be the additional costs needed to gain 1 QALY. So QALY is a measure that takes into account duration and quality of life. 1 year of life lived in perfect health is worth 1 QALY. We use a willingness to pay threshold of $100,000 per QALY gained, which might seem a bit high, but medications and other interventions are commonly funded under this threshold. This figure shows the main results of this review. The ICERs are displayed in the vertical axis, and the closed circles indicate studies with moderate certainty. So if the payer is willing to pay $100,000 to gain 1 QALY, we can see that most studies would fall below that threshold and therefore would be considered cost-effective. So we concluded that fall prevention exercise programs delivered to older adults living in the community are likely to be cost-effective. This study has just been accepted by the British Journal of Sports Medicine, so please check the full text for more details and more results. Thank you.
Hello, I'm Juana Williamson, a technical officer in the Physical Activity Unit at WHO in Geneva, and I was involved in supporting the work to develop the 2020 guidelines on physical activity and sedentary behaviour. And in order to disseminate those guidelines, we developed a number of different materials, which I'd just like to share with you now. So we published the guidelines both as a full document and as an at-a-glance brief executive summary of the recommendations in all 6 UN languages. But in addition, they've been adopted and translated by a number of different countries and made available in other languages too. But to disseminate the guidelines, we also developed a video which captured the concept of every move counts, and a number of social media materials, both short reels, social media tiles that were used and that focused on different population groups. We've also recently added some short videos targeting specific population groups, amongst them older adults, and looking very carefully at the type of activities that these different population groups can do. And all of these materials are freely available on a Trello board, and I've put the address there for anybody who might be interested in using them. And again, they've been translated into all 6 UN languages and a number of non-UN languages, thanks to the collaboration of ISPA at the time of the launch of the guidelines. So I think we may see one of the videos later on, but this is just the snapshot of the video that was recently developed, specifically targeting older adults over 65. So as I say, all these materials are freely available, and we're very glad if they're shared and used more widely to get the message out about every move counting and the different ways in which people can incorporate physical activity and limit sedentary behaviour in their everyday life. Thank you very much.
Wonderful to see the evidence and the guidelines and the resources that we have to work with as we move forward and promote physical activity for older persons. As I said, we're fortunate today to have representation from presenters from a number of different countries. We're now going to hear from people from 5 different countries who are going to describe for us some substantial and inspiring work that's being conducted. Firstly, we have Professor Heather McKay. Heather is a professor in the Faculty of Medicine at the University of British Columbia. She leads the multidisciplinary active ageing research team at UBC. Her research evaluates the role of novel, scalable health promotion interventions on older adult health, mobility, and social connectedness. Thank you, Heather.
Okay, thank you. Can everyone hear me? Good evening. I'm going to share my screen with you now and put this into present. And can everyone see my screen? Ben, yes. We're good? Okay, thank you. I'm speaking to you this evening here in Canada from beautiful Vancouver, where I am very privileged to live, work, and play on the lands of the Musqueam, Squamish, and Tsleil-Waututh First Nations people. In the 10 minutes that I have to get us started, I'm hoping that I'm going to convince you that scale up matters. But I'm thinking you're at this webinar because you already believe the scaling up effective innovations matters. If we are going to achieve a population health benefit, we have to figure out how to take innovations that work at a smaller scale and move them into practice at larger and larger scales. The definition of scale up that I use, and I'm thinking about today just to put us on the same page, is very simply speaking, the process by which interventions are shown to work on a small scale in a controlled condition are expanded under real world, rather messy conditions into broader practice. We conceptualize implementation and scale up quite differently. And we know the language varies depending on where you are in the world. We see these terms as being conceptually distinct, but not mutually exclusive. You can implement without scaling up, but you cannot go to scale without implementing. So I think right now, and my feeling, and based on the literature I'm just about to share with you, scale up resides very firmly in the too hard basket. And I'm really hoping that we can remove it from there and get everybody excited about taking the innovations that they've shown work to larger and larger scale. Samantha Gray is a doctoral student that I had the privilege to supervise, and Samantha conducted a systematic review, systematic review of older adult physical activity interventions. And of those 137 that met her criteria, only 4% of them were taken to scale. So again, I really think that as a discipline, or those of us in health promotion or kinesiology or any other discipline, can do a much better job than we have done so far. Why is it that scale up happens so infrequently? Well, I think it takes a long time. It's expensive, but the implementation and scale up science itself are really it's quite a dense science. And I would venture to guess, or venture to say, a murky science. There's a vast array of theories, models, frameworks, and indicators developed, first of all, in the health services sector that we're trying to adapt and utilize in health promotion. And that can cause some problems. We tried to simplify this process somewhat by conducting a Delphi study with implementation scientists in physical activity and behavioral nutrition who had between 5 and 25 years experience in implementation science. And in this paper shown here, we didn't. The results showed that these implementation scientists recommended 3 implementation frameworks, 3 scale-up frameworks, and 15 implementation indicators that comprised a minimum data set as a place to get going. There's lots of literature out there. There's lots of other ways to implement and scale up innovations, but this might be a nice place to start. It provides you just a little bit of a pathway to get you going. The scale-up framework that we use most often is shown here, and I absolutely love it. This is Yame's framework. He's in global health and does work in low and middle income countries, and suggested that there are a number of factors that influence scale-up, and these factors actually surfaced in our evaluation as well. When you're scaling up, you want to consider and probably adopt a phased approach to scale up. It happens over time. You need to engage those in the local community. Practice-based evidence is going to be your friend. You need to engage them early. You need to keep them involved through the life course of the innovation. The intervention should be simple, and the delivery mechanism should also be simple, although scale-up can be quite complex. And finally, research also is your friend, that knowledge to action cycle whereby we're implementing, we're evaluating, we're adapting, we're implementing again continually to keep in what works and remove what doesn't is ultimately important over time. So the case study that I'm sharing with you today is based on what you've just heard really well presented to you in the opening, in that in Canada, as in other places around the world, our older adults are not active enough to meet health guidelines or to meet physical activity guidelines. So we developed, again, co-developed with community partners, older adults, and our government, our Ministry of Health, Choose to Move, which is comprised of 3 components: a one-on-one consultation between the older person and the activity coach. That's where their goals are set. They choose activities they like to do and will stick with. This is a choice-based model. Motivational group meetings is where they get together. This is the social element. They loved the social connections more than they loved the physical activity. This is a very important part of Choose to Move. And then activity coaches engage the older adults in telephone check-ins as well. This is a busy slide, and I'm sorry, I don't have time to go through all parts of it, but you can see here that we implemented Choose to Move across 4 phases in 8 years. Along the bottom are the years beginning in 2015, during which we conducted Choose to Move, and you can see the number of programs and participants that we engaged over time. So I'm going to have you flip your eyes to the arrows at the top of these, the curved arrows at the top, and just share with you that between each of our phases, we conducted a formal adaptation process so we could understand what worked in the context within which we were implementing and what needed to be changed. When COVID struck Canada and all countries around the world, we did a very rapid adaptation and changed Choose to Move so it could be delivered at home virtually. And we changed all of our evaluation methods as well, so we could conduct our research virtually. We're very much aware, as is everyone else in implementation and scale-up science around the world, that there's this constant tension between adaptation and fidelity. We need to adapt to stakeholders, we need to engage them, we need to listen to them, but we want to maintain fidelity to an intervention that we probably showed worked in an efficacy trial. Results of Choose to Move have been really positive. In phases 1 and 2 and 3, we showed that physical activity and mobility increased significantly, social connectedness increased, and loneliness decreased. In phase 3, we saw what is called a voltage drop, whereby the magnitude of the effect starts to diminish as you go to larger and larger scale, but the results were still significant from baseline. Choose to Move has been scaled up now across 714 programs to about 7,000 older adults across all regions, large cities, small urban centers, remote rural parts of British Columbia and Canada. And to close, there are 2 takeaway messages. First, the role of a central support unit is key. It's important to adapt the intervention to political, social, and cultural environments. The central support unit has to demonstrate credibility, not to academia or to science, but credibility to the community, and that they know who lives in the community and meet their needs. And the support unit also needs to provide the technical resources these communities need. And finally, partnerships are the cornerstone of scale up and trust, and building trust early on in the implementation and scale up process is key to success. Thank you very much.
Thank you very much, Heather. Tremendous practical insights that you've shared there. We're now moving to 4 shorter presentations. Firstly, and I'll just let you know who they're going to be from. Firstly, we have Professor Aphrodite Stathi from the University of Birmingham in the United Kingdom. Then we'll move on to Dr. Etienne Ne from the Research Organisation for Health Education and Rehabilitation in Cameroon. Following Etienne, we'll have Professor Emeritus Lindy Clemson from the University of Sydney in Australia. And then we'll finish up with Professor Adriano Akiro Hino from the Pontifical Catholic University of Parana in Brazil. And please remember that we encourage you to use the Q&A opportunity to ask questions, because following Adriano's presentation, we'll have a time for questions and discussion.
Thank you, Ben. And does everything look okay?
Aphrodite, you just need to swap your display over. We can see the presenter mode.
Okay, that's better, eh?
That's better, yeah.
Okay, thank you. Good morning from Birmingham, UK. It's quite dark outside, but it's fantastic to be in such a nice company. So I'm going to talk briefly in my presentation about 2 randomized controlled trials, the REACT study and the A study. What both studies share is the focus on supporting older people over the age of 65 with mobility limitations to disrupt, to delay or postpone the downward spiral journey from moving from independence to dependence and frailty. What both studies have done is try to implement physical activity and exercise programs in order to support older people to remain mobility for as long as possible in their lives. What both studies did is that they co-produced the interventions with academics and non-academic partners, and both studies delivered the intervention via partnerships with community providers. It's a very short presentation. All of the journeys for both studies have been depicted in several presentations and publications. So I would welcome my colleagues and people who listen to our podcast today to visit them. Starting with the REACT study, the study started, the reason behind the REACT study was the attempt to address some major gaps we had in literature. And those gaps were first, not sufficient evidence about the effectiveness and value for money for long-term community-based mobility programs. What REACT tested was a one-year group exercise and community-based program targeting frail and pre-frail older people. It was both an effectiveness and cost-effectiveness study. And the other gap that the REACT tried to address was the sustainability of effects 6 or more than 6 months post-intervention. So REACT set as a primary outcome mobility performance at 24 months, and that was 12 months post-completion of the intervention. The first success of the trial is that it managed to recruit a sample of people representative of the UK population of people over the age of 65. We recruited 777 people with a mean age of 78 and classified as frail and SPPB, the primary outcome score of 7.8, which denotes physical mobility frailty. The second success was at all time points from 6 months to 12 months, and most importantly, at 24 months, which was set as our primary outcome, the intervention group was statistically and significantly better than the control group. And that significance sustained also in terms of clinically meaningfulness between the two groups at all time points, and particularly important at 24 months, where the older adult, the intervention, all the cohort were not part of the intervention anymore. The clinically meaningful importance of the findings of the study were also stressed by the health economic data, the effectiveness, the cost effectiveness of the study, where we saw that the savings of delivering the trial offset the costs of the program with significant benefits, particularly in hospitalizations and improved health-related quality of life and significant qualities. What we delivered in REACT, it was 64 sessions throughout those 12 months, with two distinct phases, the build-up phase and the keep-it-up phase. More intensive phase at the start of the trial with a group exercise and social session program, and also a maintenance support behavioral program. So the program tried to incorporate the physical activity guidelines about strength training, functional ability, and included a lot of social interaction. And it met, as I said, the physical activity guidelines, focusing particularly on building strength. Where we are now in the start of the rollout journey. We deliver REACT in UK, in the city of Bristol, continuing our partnership with community providers there, and hoping to being able to roll out REACT program nationally. And moving quickly to the ACE program, although it shares a number of similarities with REACT, it does not provide a specific exercise group-based program as REACT did, but it tries to address a major barrier for older people's physical activity participation, and that is the lack of willingness or readiness or motivation or fear to get out and about. So what ACE tries to do is we pair inactive, less mobile older people with active peer volunteers in an attempt to help them to break down the barriers, engage socially, and get out, explore opportunities in the local community, and take advantage of what is available in their local community. Key messages from both trials is that what we've seen in the REACT study is that strength training exercise, multimodal exercise is extremely important. A session of at least once a week helps sustain these important benefits. And in ACE, although we want people to engage with everything, any activity they would like to do, knowing the important benefits of the strength and balance activity, we particularly target those activities as part of that intervention too. This is an ongoing intervention. We are now in year 2, and hopefully in another webinar in the near future, we will be able to share the results. Thank you very much.
And we're moving directly to Etienne now.
Thank you very much. I'm just going to present the situation of Cameroon with respect to physical activity rather than some results. I am Etienne, a physiotherapist and cardiac rehabilitation specialist from Cameroon. Cameroon is a lower middle income country in Central Africa with more than 200 ethnic groups with 2 official languages and a population of about 28 million. The burden of the risk factors and cardiovascular disease burden in Cameroon is actually huge and increasing. Prevalence of hypertension is increasing with a national average of about 31%, and the incidence of stroke is increasing with case fatality increasing as well from about 14% to about 24% over a decade, and cardiovascular disease account for majority of hospital admissions, with heart failure and stroke being most of it. In 2012, 12% of Cameroonian deaths were all attributed to cardiovascular disease alone. However, physical activity, it is very low, and in line with global evidence, physical activity, population physical activity is declining. Some studies conducted in Cameroon demonstrated that rural dwellers were slightly more active than urban counterparts, and that those who considered themselves really active in the urban area were just as active as those who considered themselves less active in rural cities, in the rural areas. In terms of physical activity policies, one study conducted by Tata and colleagues demonstrated insufficient physical activity policies and implementation, and that physical activity policies identified across 7 ministries were more focused on recreational activity than health. So the health benefit of physical activity were not broadly acknowledged in policies, downplaying its importance, and no policy was identified from the Ministry of Transport, which is a key ministry in providing and in promoting physical activity. There was some evolution in policies, and from competitive sport to physical education, and then health, which now include older adults, and those policies only came into place in 2010. So our ongoing project in Cameroon aim to collect data from both patients and physiotherapy And we aim to evaluate physiotherapy practice and the challenges of integrating physical activity into care. We aim to explore experiences and challenges of patients at risk or with cardiovascular disease and the uptake of physical activity. Overall, we aim to develop contextual recommendations and guidance that can be used to increase uptake of physical activity and exercise in clinical practice among physiotherapists in Cameroon. So we hope that data generated from this study will be used to improve and to develop policies that we can integrate into relevant sector. At the moment, the study is still ongoing, and if you're interested for any collaboration or support of any kind, you can join us here. Thank you very much for listening.
Thank you for inviting us to share with you Stepping On, our evidence-based community fall prevention program. Stepping On uses a small group learning environment to enable behaviour change and to use protective strategies in order to improve confidence and reduce falls. It runs for 7 weekly sessions with the booster session 3 months later. And the aim is to empower the participants so that they can identify their own personal fall risks, to make decisions and adopt strategies to prevent falls. The program's manualised for facilitators to implement, and there are many resources, including an exercise manual and other handouts available in numerous languages. The content draws on current evidence and what works. While exercise, balance and lower limb strength are core to falls prevention, it addresses multiple fall risks such as spotting hazards at home and finding solutions, community safety, recognising unsafe and safe features of shoes, and things like how to initiate medication reviews. But it's important how it's done, and that's through various learning activities, brainstorming, guest appearances, a focus on key messages. We use lots of props, sharing, and most important, specific homework goals after each session. It makes all the hard work by Stepping On facilitators so worthwhile when they receive unsolicited feedback. And this is Fran back in 2003 after an early program run by Megan. She said, "I found it useful and helpful, and it made me realise there is more to life than just getting old. Once I understood the reasons behind the exercise, I appreciated why. I latched on to the expert presentations that were applicable for my particular situation. I find I can raise myself from chairs with much greater ease. I have confidence when out walking, and apart from remembering heel toe when walking or looking straight ahead, I have no trouble getting around. In fact, I feel a new woman." Fran's comments reflect many we have received over the years. Stepping on from evidence to impact. So we first published our randomised trial back in 2004. Showing a 31% fall reduction. We now have about 18 studies supporting this program, mostly from the USA. A process evaluation helped us understand key features that ensure fidelity. Other studies have demonstrated behaviour change and maintenance of physical outcomes. And our major implementation and scale-up of Stepping On, led by Jane Mahoney in the US, demonstrated our trial results could be replicated in practice. A series of recent observational studies by Serene Paul showed that health service use increases for the target population, but Stepping On appears to mitigate the effects of this. Important news for policymakers investing in fall prevention. The manual details how to run the program, the underlying conceptual basis, the session objectives and structure. It's available from Sydney University Press, also Amazon and Book Depository. And Staying Power is a complementary book aimed for older people and their relatives who we all know need to also understand what to do and how. And finally, where to go for training. Megan Swan runs training and support in New South Wales. There's her website. And in North America, Jane Mahoney has set up the Wisconsin Institute for Healthy Aging, and they run training for stepping on facilitators and master trainers. So thank you very much for joining me today.
Hi everyone, my name is Adriano Kiraino, and I'm gonna talk a little bit about built environment changes to promote physical activity in Brazil. I'm not sure if you are aware, but Brazil has one of the highest prevalence of insufficient physical activity in the world. So interventions to promote physical activity in Brazil is very needed. When we think on large-scale strategies, changes on the environment are very promising. Ones can reach a large part of the population. Even though we still need more studies, the evidence available allow us to identify characteristics that can affect the physical activity among older adults in Brazil. So the next step would be how to make these changes happen. As researchers, we have basically no power to make those changes, so one possible strategy is to empower the citizens to put pressure on who can. In this scenario, the participatory research approach could be very useful. So the Our Voice project, led by Professor Abby King, used the citizen science framework, and this framework help us first to make the citizen scientists who will evaluate their neighborhood, help them to find common themes and priorities and solutions, and then put them together with policymakers who actually can have more opportunities to make changes in the environment. Here there are some examples of older adults taking pictures and recording why they are taking those pictures. So basically we have conducted this with 67 older adults. They were able to identify functional, safety related and aesthetics and land use barriers to physical activity, and the app that they have used, the Discovery Tool app, was very acceptable. So it seems very doable for this population in Brazil. So here is one example of this framework being used in a large scale. This is a non-profit organization that organize annually a national campaign to raise awareness and engage the population in favor of accessible and walkable cities. They basically invite the population to record locations where sidewalks improvements are needed. They do this with an app, and then the results are released to advocacy and send it to policymakers. In Brazil, it's mandatory. The municipalities with more than 20,000 inhabitants have a master plan. So this master plan should count on the participation of population in its elaboration and supervision process. So you might imagine that the participation is not very high. So participatory approach and framework as Our Voice, it is an important strategy. Mainly to bring up teams as an important priority in terms of health and safety, help to understand the context-specific attributes of built environment in Brazil, promote awareness about the importance of age-friendly environments, and promote empowerment for the community about their voice and strength to promote changes in the environment. Thank you very much for your attention.
thank you to all of our presenters. And you will have seen that some questions have been posted as they're presented. I'm going to hand over to Kathy now to respond to some of those and open up opportunities for more discussion.
Fantastic. Thank you so much, Ben. And what an amazing collection of speakers. Thank you, everyone. Heather, we've got a question for you from Leanne Hassett. She's asking about the importance of keeping, you've highlighted the importance of keeping partnerships going and engaging partners in projects. What strategies have you used with Choose to Move to do this over such a long period of time?
Yeah, and whatever works in your setting, but for us, it's just an ongoing interaction with those at different levels. So we think very carefully about who we would like to have or who we need at the table to allow us to implement the intervention. So for government, that's different than community organizations, which is different than than others. But with government, I mean, that was my job. So I've been working with the government for about 25 years, and it was most of what I did. And it was just constantly meeting with them, doing policy rounds, asking them what they needed from us rather than asking for something from them. So it's pretty straightforward. It's constant communication and just being authentic and true about what you can do in most cases to solve their problems, I guess.
Fantastic. Thank you, Heather. While we've got you, Heather, we might ask you Bill Bellew's question as well. So he's got wondering what people's thoughts are on higher level governance or task forces, such as we believe has been set up in the UK with falls prevention. And avoiding kind of fragmented silos. Have you got any experience with that sort of thing in Canada?
Yeah, no, not so much. I mean, it sounds, Kathy, like you probably have more in the falls prevention world. Why don't you tackle that one?
Well, we're actually keen to learn from what's been happening elsewhere. We're keen to start something like that up in Australia. But actually, we might throw that to Aphrodite, because I believe she's got some initiatives that are actually about different organisations working together to enhance physical activity.
Hi, yes, I mean, we do have the experience of task forces in UK, and I would say the comment about breaking silos is the important thing here, because what we've seen a lot in promotion of physical activity is number of organizations doing things in parallel without communicating and working together. And I think this is the importance of having task forces in places where people who have the same agenda, more or less, and the same aims coming together, and they share the knowledge and they share also resources. So instead of diverting resources to a lot of similar things, we group together as task force, and we can be much more efficient and much more effective.
Fantastic. Thank you, Aphrodite. Now, both Fiona and Heather are happy to say something else in our next couple of minutes. We might throw to you first, Fiona.
Yeah, well, thank you. I think that's a very important point about the partnerships. And of course, all of you on this call and webinar would know WHO recommends that we need to strengthen the partnerships to avoid the silos, work across all sectors, and task forces are certainly one way, working groups, coordinating mechanisms. And let's remind ourselves, WHO called on all countries to set up these NCD coordinating partnerships. However, physical activity may not be in the center of that. And I ask all of you to look and talk to your governments about that and get involved. Make sure the ministries of sport, ministries of all the relevant parties need to be involved on that. And Kathy, can I just pick up one point that's coming through the chat, and that's about the benefits that come and the cost savings. And we heard that right at the beginning of the webinar about the savings that can be made if we can prevent falls and keep people active. And that data needs to be celebrated, communicated and disseminated. So let's all take on the weekend of International Day of Older Adults to use it for great advocacy. Thank Thanks, Kathy.
Thanks so much, Fiona. Wise words as always. Back to you, Heather.
Yeah, and I didn't understand your question, Kathy. It's 11 o'clock at night here, and I think I was like, what? But we always work in large interdisciplinary cross-sectoral teams. That's the way we do all of our work. We don't always call them task forces, but we depending on who we're working with, we just make sure that there's representation and a broad range of representation from across community organizations, government partners, and so on. So yes, task forces are, I'm just piling on here. Task forces are the way to go, for sure.
Oh, and Aphrodite, over to you.
You're on mute, Aphrodite.
Sorry, just to add to this discussion, I think the importance of having strong data about cost effectiveness is something to highlight even further. The experience of the REACT study, which was effective and cost effective, what I've seen trying now to roll out and scaling it up is that this data, the cost effectiveness data, is what drives strongly the agenda of helping the REACT program being nationally rolled out. And so we start having an extreme, database about cost effectiveness of physical activity programs, and we need to highlight it and make a lot of cases about that, because there's always going to be a competing interest about resources. So we need to bring physical activity up there in the ranking order.
Fantastic. That's an excellent point to end on. Thank you so much, Aphrodite, and I'll hand back to you, Ben.
Well, I think you'll agree with me. It's been a full and inspiring program today, and I want to thank all of our presenters for taking the time to tell us about the range of different initiatives that they've been involved with and sharing with us lots of practical insights as well. I want to thank the co-organisers of today's event. I think this is an excellent way to celebrate the UN International Day for Older Persons. And some of you may know that the theme for this year is the resilience of older persons in a changing world. And I'm sure you appreciate that promoting active living and wellness and independence is a great asset that supports resilience and older people's engagement in communities. So we'll end today's session. I wish you all well in any activities that you have organised for the UN Day. It is actually the 1st of October, so we're a little bit ahead. It's happening tomorrow. And of course, wish you well in all of your efforts to develop and engage programs for older people to promote active living. Thank you.